First of all, a couple reminders. Please check into the session if you can. There's the QR code. And also don't forget to provide feedback at the end of the session through the Whova app. There's a rate session feedback button. Let us know what you're thinking with that. We have 3 concurrent sessions currently. This is the one about the education session. I'm Ben Sendejas. I'm a surgeon at Boston Children's Hospital. I'm here with Pam Choi. She's a commander in the Navy and at the Naval Medical Center in San Diego. And we have great talks today. We're going to try to stay on time. Love the questions, so please participate. And the first talk today is by Claire from Boston Children's. Dr. Ostertag-Hill will talk about validation of an anorectal malformation trainer, whether high-fidelity models simulate real life. Of note, she has her model or trainer right here if anybody wants to look at it.
All right, good afternoon, and thank you so much for the opportunity to share our work. We have no disclosures. Simulation in surgical training offers an attractive modality for teaching technical skills in a safe and controlled environment. It can aid in improving clinical and operative performance, reducing operative times, and reducing errors. Anorectal malformations, or ARMs, are one of the rare congenital anomalies that are seen by pediatric surgeons which require complex surgical reconstruction. However, the average number of ARM repairs done by pediatric surgical fellows and attendings is quite low, with American Pediatric Surgical Fellows doing an average of 15 cases across their 2-year fellowship and recertifying American surgeons doing only 2 cases annually. We therefore aim to design an easy-to-use, high-fidelity ARM simulator. The posterior sagittal anorectoplasty, or PSARP, is an operation with reproducible steps used to repair an ARM and were recently standardized using a Delphi model. We developed the simulator to be able to reproduce all of the technical steps, as indicated here by the arrows. We designed the simulator using digital modeling software packages. The simulator was then fabricated using a combination of 3D printing, hand sculpting, and multi-stage silicone injection molding techniques. I did bring one of the simulators with me, and my colleague is going to pass it around the room for anyone who's interested to take a look. With the goals of achieving improved reproducibility and a lower labor burden, improvements were made to the manufacturing process and tooling design. The base as well as the molds that are used for the various pieces composing the insert are 3D printed. The base is reusable and a new cartridge is placed to perform the procedure. I want to show you a brief clip of this in action. We start with evaluation of the urethra, vagina, and rectovestibular fistula in the introitus, followed by dividing the sphincter complex and perisagittal fibers in the midline, and separating the anterior rectal wall from the posterior vaginal wall. Of note, the common wall in the simulator is quite thin at 2 millimeters. Rectal length is then gained. The procedure is continued with the perineal body repair, tacking of the posterior rectal wall, and finally, anoplasty and closure of the posterior sagittal wound. To validate the simulator, we performed a cross-sectional observational study at IPEC 2022, recruiting surgeons of varying levels of experience with performing a PSARP. Experience with PSARPs was self-reported. Experienced participants had performed 10 or more PSARPs and novices less than 10. Each participant performed a PSARP after viewing a short demonstration video on the model and receiving an instructional guide based on the Delphi consensus methods for PSARP steps. Each session of the simulation was recorded and independently assessed by 3 expert pediatric colorectal surgeons from different institutions. They were blinded to operator identity and experience level and used both a standardized general skills, or OSATs, and a PSARP step-specific assessment tool. Here's a breakdown of our study participants. We had 11 experienced participants and 16 novices. These groups had similar ages and gender distribution, and the experienced participants generally had a higher level of training overall. We previously demonstrated that the simulator was rated quite highly in terms of its external appearance and anatomic representation, as well as it being a valuable tool for training and maintenance of skill. The OSATS checklist permits an objective assessment of overall surgical skill. Significant differences between the groups were observed for multiple items in the OSATS checklist, including respect for tissue, instrument handling, flow of operation, and knowledge of the specific procedure, with inter-rater reliability scores indicating moderate reliability. Therefore, the model combined with the OSATS tool was able to distinguish between experienced and novice participants in terms of their surgical technical skills overall. Additionally, pediatric colorectal raters indicated that the model combined with the PSARP-specific assessment tool could distinguish between the experienced and novice participants on all steps of the PSARP procedure, with inter-rater reliability scores indicating good to moderate reliability. We are currently working to develop a male version of this model with a rectourethral fistula. The base will remain the same, but the cartridge will be exchanged depending on the type of repair that is to be simulated. In conclusion, the combination of the simulator with the utilized assessment tools provides validity evidence to discriminate between experienced and novice participants. Given the low number of PSARPs that are performed annually by surgical fellows and attendings, the simulator may offer a high-fidelity training tool. Thank you very much, and I'd be happy to answer any questions.
Thanks for your talk. Parker Evans from Vanderbilt. Just curious what the time and monetary cost is for developing one of the models now that you guys have kind of got the process down. Thanks.
Yeah, thank you for that question. So we worked closely with our simulation engineers at Boston Children's to develop this model, and it was in fact a multi-year process to go from the beginning to the current model in multiple iterations that we performed the PSARP on and then made modifications to best represent the actual procedure. The cost is ultimately going to be dependent on partnering with an external vendor. All of the models that we have created to date have been printed in-house at Boston Children's, but our ultimate goal following development of the male model would be to partner with an external vendor who's able to produce these models in a faster amount of time, but also at a lower cost.
Andreas Marsoni, Upstate. As we were talking about this in our education breakout yesterday, what's your plan for a construct validity study? How are you going to do that?
Excellent. So that's an excellent question. So to date, we had done both surveys from participants who had performed the PSARP on this model, as well as having blinded reviewers rate them. We're going to do continued testing with this model, and we hope that potentially next year we can present more data on this.
I'm sorry, I may have missed it. So have you validated the models with fellows? Like, for example, like if they use the model, like had they been rated in their performance in doing the PSARP in the OR?
Excellent question. So we have not done that study to date. Our goal at our institution would be to have our fellows perform a procedure on this model before they go to the operating room to perform this procedure for the first time, and then repeat it afterwards as well, and ultimately obtain the data that you are talking about.
Pat McGovern, Phoenix Children's. Really great model and system, and just wondering what, if any, plans do you guys have to be able to spread it out to other training programs at this time or in the future?
Sure. So ideally, once we partner with an external vendor, I think that'll be a much easier possibility. We're currently in discussion with one of the colorectal meetings that's held annually to be able to provide them with a number of models for the fellows to perform this procedure. And our hope is that that may happen as early as later this year.
Thank you.
Great. Thanks, Scott.
Thank you.
Next, we have Amelia Gavalik with Improving Diversity, Equity, and Inclusion in Pediatric Surgery, an innovative mentorship program.
Good afternoon. My name is Amelia Gavlik, and I'm a rising fourth-year medical student at the University of Cincinnati College of Medicine, representing our nationwide organization of the Alliance of Pediatric Surgeons Growing and Advancing Representation. We have no disclosures. The diversity of the pediatric surgery workforce currently does not reflect that of its patient population. We developed a national longitudinal mentorship program called the Alliance of Pediatric Surgeons Growing and Advancing Representation in May of 2022. 1 year later, we report the composition of APGAR, the perspective of its participants, and its impact. 17 mentorship pods were comprised of participants varying from high schoolers all the way through faculty pediatric surgeons. Pods were led by faculty pediatric surgeons and met roughly quarterly, and programming took place largely over Zoom for any large group events, including all pods, and any other virtual format that the pods chose amongst themselves. A survey was administered at the time of pod creation in May of 2022, and another survey was created and administered in May of 2023. These are our current APGAR events that we've held to date. The initial pod launch, as mentioned, was in May of 2022, and some of the other ones we've had since then are listed here. We've had several pod reunions, as we call them, throughout this time, and we have innumerable events within each small pod that they've held themselves that are not counted on this slide. The participants as of May of 2023, so last year, was 126 students and trainees, 29 faculty, and 54 institutions represented. I'm very proud to announce that since this time now in May of 2024, we've grown to over 170 participants with almost 80 institutions represented. Of the survey respondents, we had a very high completion rate at the pre-survey, given that it was required to register for the event, and a lower rate at post-survey. 104 unique respondents, and 22 of them completed both surveys. Of the respondents, the median age was 26 years of age, and our group is majority female. 57% of participants had prior clinical experience in pediatric surgery, and 43% had prior research experience in pediatric surgery. The composition of survey respondents in terms of race and ethnicity was very similar to that of our overall participants, with 35% being white, 28% being Asian, 18% Black, and then a large majority of, or a large proportion of Hispanic and multiracial others. The majority of folks in our organization are medical students, but there's a very heavy representation of surgical trainees and undergraduate and high school students as well. So, participants were asked to rank various factors influencing the selection of a career in pediatric surgery. These factors included compensation, work-life balance, intellectual challenge, opportunities for research, length of training, long-term follow-up of patients, and job market following training. Significantly more participants ranked the intellectual challenge of pediatric surgery as being very or extremely important at the post-survey point. Additionally, participants were surveyed on their perceptions of pediatric surgeons themselves before and after the pod initiation. 36% agreed that pediatric surgeons had good work-life balance prior to pod initiation, compared to 54% post-survey, so that increased. And then they were consistently considered to be good team players with 97% and 98% pre and post-survey. None of these comparisons were statistically significant. The vast majority of our participants were glad they joined APGAR. They felt that they could reach out to their pod for advice and felt that their pods were helpful for networking. Half felt that participation in this organization helps them prepare for a career in pediatric surgery. This program may increase student and trainee interest in pursuing pediatric surgical training, as well as improve perceptions of the field as a whole. With the increasing growth of our network, future assessments will be made to quantify its effects in the pediatric surgery pipeline. We welcome any students, trainees, or faculty interested in joining APGAR. Please reach out if you're interested, either to me individually or to our APGAR email listed here. Happy to take any questions, and thank you for this opportunity.
Open for questions, anybody?
How did you, I vaguely remember seeing advertisements for APGAR across Twitter, but I was just wondering, how did you recruit trainees to this program, since they're from so many different institutions and are, such a diverse population?
So Twitter's our big avenue right now, and then we also rely on a lot of word of mouth from faculty and then trainees at their own institutions spreading the word. At Cincinnati, where I'm located, we've gained a pretty good following there just by engaging folks through word of mouth.
With the survey, did you happen to ask them what could have been better or what could have been more engaging, or like in terms of things to do differently for next year? Did you get a sense for that?
Yes, we had a free form response for that, and it varied based on who was answering naturally, as the undergraduates had more questions about medical school and residents had more questions about applying for fellowship. So that's been part of our workshops this past year since the survey was completed, was doing a little more individualized approach per pod.
And did the faculty answer the survey, or was there any like feedback from the faculty in terms of how it was for them, in terms of benefits or things that the faculty may have gotten out of this?
We have no formal survey from the faculty because the survey was for the trainees and students specifically. But that's something to look into for the future, especially as we're gaining more faculty regular engagement.
Okay.
I think you had a 36% post-survey response rate, which is actually pretty good for surveys in general, but obviously it just seems like a big difference from the mandatory 90-something% response rate you had in the beginning. Does that concern you at all, like in terms of the limitations of the study?
It certainly is a limitation that we had a lower proportion of people responding to the second one. We felt that maybe we shouldn't force people to participate to register for the event, which is why we changed that. So that certainly is a limitation with regards, but I think with every event we've gained a more, what's the word I'm looking for? It's like a more strong following. People are a little more dedicated to it, so are a little more apt to give us feedback, whereas a year ago, maybe they weren't as dedicated.
And then, for these trainees who are participating in this program, did you find that there was like a consistent rate of participation longitudinally, or was there some dropout rate with time?
Certainly some dropout rate with time. Dropout's hard to assess because some folks just come to the events that they can. Naturally, a PGY2 resident who's not yet in their lab years is a lot busier than someone in their lab years or a medical student. So sometimes we have folks that don't come to as many events, but we can't really assess true dropout rate unless we ask people if they were no longer wanting to participate and they told us no.
All right, thank you very much.
Thank you.
Okay, so our next presentation is going to be by Dr. Fabio Botello from Montreal Children's, and it's entitled Virtual Reality for Pediatric Trauma Training, a Face and Content Validation Study.
Okay, so hello everyone. It's a really pleasure to be here. It's my first APSA presentation, so I think it's a big day for any pediatric surgeon. I'm originally from Brazil, spent some time in Montreal doing my PhD, some clinical training, and I'm going to talk about how I can use virtual reality for pediatric trauma, something that I really like. And disclosure, I'm co-founder of PTVR. This is the platform that you're doing for training pediatric trauma, but I'm not receiving any money from that. It's only for research, so I think I'll be fine. And the reason that we decided to do that is because I was really upset in the way that you are treating injured children, at least in Brazil. My supervisor over there, Dr. Simone, is here. We did a master's. I did my master's with her. And then we saw that doctors could miss up 66% of the steps while treating injured children. This is a phenomenon not only in Brazil, but across the world. And actually, the current trauma courses, they are available to less than 10% of the physicians worldwide, so it's really expensive. And doing some systematic reviews at McGill, we saw that virtual reality can really try to decentralize trauma education. So then we create this platform. As you can see, it's really immersive. It's a multi-user platform, so you can train non-technical skills. You can interact with the patient, do simple procedures, perform a fast exam, and really train the basics of pediatric trauma. And not only that, but really teamwork and all the non-technical skills. But of course, once we design it, we are not satisfied with that. We really would like to see if this really works before implementation and before distribute it. So we did our reviews, our discovery part. Now we did our design, so we're doing our face and content validated studies. And this is what I'm presenting here today. We invited 11 physicians from 8 different countries to really test our platform. We applied the face and content validated surveys. Face is to see the anatomy of the platform, if it's realistic, if they couldn't identify the injuries. The content, if it's meeting the teaching goals that we would like to provide with that platform. And important for virtual reality to apply the cyber sickness survey, because we saw some studies that people getting sickness, like motion sickness symptoms, So I decided to apply that. And you can see the results. This is a Likert scale. 1 strongly disagree, 5 strongly agree. You can see for the face validity, the anatomic structures were really realistic. The interaction was good. Most of physicians agree that they identified all the injuries, and the virtual patient met their expectations. For the content, they reported that it's good for primary survey, it's good to train secondary survey in pediatric trauma, it's excellent for non-technical skills. We had a problem with technical skills for virtual reality that we know we don't have haptic feedback, so that can be some issue. But even though they also agree that can be something useful. But for cyber sickness, we didn't have really encouraging results so far. As you can see, most of the participants, they have some kind of like discomfort using the platform. But when we assessed that, they told that was more because they couldn't focus really well. They had blurry vision, the eye strain. So we really believe that we didn't spend enough time to adjust the headset. And this is really important. Even for the Oculus 2 that you're seeing here, we can have like interpupillary distance adjustment. So these are the things that we should really try to do before, so then they can have a better experience. So in conclusion, it's really simple, this study, but it showed the potential. We could see that there is an adequate face, the design of and the content is really good. The cyber sickness deserves further assessment. The next phase would be to do a feasibility study. We're going to do like a proof of efficacy trial comparing high fidelity mannequins and see if that is really something that we should go the next step that would be to spread this. And I really believe that we need to find innovation that decreases inequity. So we are always doing research and doing high fidelity mannequins, expensive simulation labs. But I needed to close the TLS center back in Brazil because the American College of Surgeons are not allowing us anymore to use live tissues, for an example. And why we are doing like this kind of innovations, so if we're increasing the inequity. So I just invite you all to, when you do some research, some innovation, try to think about the cost effectiveness, if we can really spread that to the world, as I was using here in my MSF mission. So I think this should also be our goal. So thank you very much. I'll be more than happy to answer your comments, questions, help me to develop this platform better. Thank you.
I think that's really great work. Once you have the trauma education built out, do you see a lot of avenues for additional surgical education for teaching, basic pediatric surgery across the globe and with this device?
So you mean for general trauma, too?
Well, just like, any surgery or any sort of, can you build it out to operations or any sort of care that would be needed?
Yeah. So for surgery, like procedures itself, we have the problem of the feedback, like the haptic feedback. Although there are some studies that telling that even technical skills, 70% are decision making. So I need to choose the right like equipment, choose the right the anatomic landmarks. I'm optimistic. I think we can do everything with VR until we have better solutions to apply, like the 3D modeling, the mannequins. So why not do it and spread it right away so people can increase the quality of care, even though are not reaching the 100%.
Yeah, I think it's incredible work. I can't wait to see how many kids it affects in the future.
Thank you.
Hey there, my name's Sean. I'm a research fellow from Boston. This is great work. I was wondering, augmented reality has been talked about as being this nice stopgap between the fully virtual world and the real world. And a lot of people have said that it reduces that cyber sickness and it frees you from building this virtual world. Have you looked at maybe incorporating augmented reality as that middle ground?
That's a really great question. The thing of augmented reality is because we still are going to need maybe the infrastructure. So when we developed this platform, we thought about some that we could do at our homes. So then we don't need any kind of infrastructure. So that was the reason. But for sure, I think even, for example, if you'd like to increase the technical skills, maybe augmented reality will be the goal. But so far, that was the main reason, because I think that the 100% virtual world, maybe we can decentralize more. So I was thinking about that, and that's the reason. But I think there are potential for everything. Even like, I'm not substituting high fidelity mannequins. We're just going to offer options. That's my idea.
Thank you.
Thank you very much.
Next, we have Dr. Azalea Avila from, with the impact of longitudinal coaching on well-being and burnout in pediatric surgery trainees, the 2021 to 2023 cohort.
Good afternoon. My name is Azalea Avila. I'm a general surgery resident at Memorial Healthcare System. And thank you for the opportunity to present our work. We have no disclosures. So the reason we did this research was to address burnout, wellness, and professional development in trainees. We're presenting this research here today to demonstrate the significant return on investment that coaching provides. We ultimately believe this is important because physicians suffer from burnout and impaired well-being more than their non-physician counterparts, with resultant loss of resilience and risk of suicide. However, it is important to note that although we are answering all these why questions here today, when you join our coaching program, we like to ask what and how questions. We don't like to ask why questions, so please don't ask us again. The APSA coaching program was created in 2020 to address burnout, wellness, and professional development in pediatric surgery residents. Our first study, which was a randomized controlled trial presented previously at APSA, demonstrated that pediatric surgery residents enrolled in coaching showed improved well-being despite the known challenges of surgical training. We know that coaching is a vehicle to take a valued person from where they want to be, from where they are to where they want to be. It provokes thought and creativity to maximize an individual's potential, and ultimately, coaching serves as a space to align personal and professional goals and values with well-being and performance. The objective of our study was to explore the influence of a longitudinal coaching relationship on the well-being and burnout of pediatric surgery residents. Our study was conducted between August of 2021 and July of 2023. The coachees were pediatric surgery residents in their first or second year of training, and the coaches were practicing pediatric surgeons. All of the training and all of the coaching were done virtually. The coaches were trained by our certified coach trainers in 3 virtual sessions, and the residents and coaches were paired and met 3 times during the academic year for 1-hour virtual sessions. Both coaches and residents completed a pre- and post-program survey which employed these validated measures of well-being presented here, including PERMA, which assessed for positive emotion, engagement, relationship, meaning, and accomplishment, Professional Fulfillment Index, which addressed burnout and self-valuation, or self-compassion, which refers to the level of prioritizing personal well-being in a person. It also assessed for gratitude, coping skills, dispositional resiliency scale, and also it assessed for intolerance of uncertainty. 20 residents, or 34% of the residents that were enrolled in the program, completed their pre- and post-coaching survey and were included in the study. 70% of them were female, 30% were male, and 50% were junior residents. In this observational study, similar to our prior randomized trial, we found that residents who participated in coaching had improved well-being, had improved self-valuation, or that self-compassion that we talked about earlier, and they also had a positive directional improvement in burnout. There were also significant improvements in coping skills, including improved work-life balance, experience with receiving feedback, and experience with opportunities to reflect. Additionally, we found that goal-setting opportunities increase resilience in a dose-dependent manner, meaning that those residents who had more than 4 coaching sessions felt that they were more resilient overall. Our study is not without limitations, as this is a prospective, non-randomized study. and we also had a small sample size. In conclusion, coaching programs have a significant return on investment for pediatric surgery trainees. In just 3 hours, along the length of 1 academic years, those residents involved in coaching had a reduction in burnout, they had improved well-being, and we also found that coaching supports activities that promote well-being, such as reflection and goal setting. This is our wonderful team, and I'll take now any questions. And if you are interested in joining our APSA coaching program as a coach or a trainee, please reach out to any of us. Thank you for your time.
Really nice job, Kurt Heiss. Could you talk a little bit more about the role of gratitude in this picture? The coaching handbook ends with Martin Seligman link to gratitude as being an important part of resilience. What did you learn from your surveys about that?
Right. So gratitude, is, as you said, is very important in the work that we do. And so with the survey tool itself, we do ask a series of questions that assess how a person is able to experience gratitude or perceive that. And, you know, having the survey before they start coaching and after they start coaching or before they start the sessions really helps them understand and gauge where they're at and where they're going.
So, Azalea, first of all, I want to congratulate you on matching this year in pediatric surgery. Welcome to the club. So, as a participant, I thoroughly enjoyed it. And my question was just about one of the challenges that just came up, and I wonder if you looked into that, which was kind of the limit setting, because there was a little bit of a difficulty separating the coaching from kind of problem solving. And I was wondering if you just had a chance to get some qualitative information from the fellows in terms of would they have liked sort of a different role sometimes, because that's not easy to clarify in the data.
Right. Yeah, that's a very good question. I'm not sure that we've actually collected that data as of yet. Maybe Dr. Hong can
comment on that. So we have not collected that data within the free text part of our questionnaire. We actually did not receive any comments about not having that. However, I will say anecdotally, I have gone across the country and I run into people who are coached, and for them, just as with the coaches, there is a need to relearn the skill set of being able to help the coachee reflect and identify their own solutions. And even the coachees that initially when that started, they very much felt this drive to want to just have somebody tell them the answer. But when they went through the discipline of figuring out their own solutions, actually really empowered them. And so even though it was a process to relearn that, once they learned it, they actually really appreciated having that skill.
Mm-hmm.
Thank you.
Thank you.
Okay, so our next talk is by Dr. Olutoye, from a surgery resident from Baylor College of Medicine. It's going to talk about the determinants of academic success in pediatric surgeon scientists.
Thank you for the opportunity to present. We have nothing to disclose. There's been a decline in the number of surgeon scientists due to increasing administrative demands, lack of departmental support, and increasing clinical volume. And interestingly, in 2018, only 16.4% of principal investigators on NIH grants were found to be surgeons. Fortunately for us, there are a number of surgical societies that provide grants and scholarships for junior faculty to help support them clinically and monetarily during this important time in their research development. And as we're in APSA, we focused on the J. Grossfeld Scholar Grant by the APSA Foundation, and we sought to evaluate this academic success of junior faculty recipients of this grant and to identify important factors that would determine their future academic success after their experience with the grant. We studied awardees from 1996 to 2022, assessed their demographics, and then their scholarly achievements as well. We used their publicly available information via Scopus, Google Scholar, PubMed, and NIH Reporter to look at their publications, HI indices, citations, and NIH grants awarded. Then we took it a step further and offered a 29-question survey that we sent out to all the J. Grossfeld scholars. This survey helped us get further information on their demographics, their contractual and actual time allocated to work duties, measurements of their scholarly achievements, their mentorship experience, and the extramural funding that they obtained. When looking at the awardees, we had 47 from 1996 to 2022. 36% of them were female, which is congruent with the APSA population. The median fellowship graduation year was 2007. 40% of them had obtained full professorship. 30% were division chiefs, 15% had become chairs, and 32% had gone on to obtain NIH funding. Looking at further metrics of their success, we saw high numbers of citations, high H indices, median of 40 publications following the grant, and K01, K08, and K23s were about 11%. So 11% had gone on to obtain these awards following the grant. 15% had gotten R03 and R21s, and 15% had gone on to obtain R01s for a 33% mentored grant to R01 conversion rate. And when you look at all the NIH funding obtained by these J. Grossfeld scholars, it amounted to $157 million, which is a 159-fold return on investment for the ABSA Foundation's support of these scholars. We then went to ask them further questions with a survey. We sent out the survey to all the scholars. We received 26 responses for a response rate of 55%. When comparing all awardees to the subset of scholars that were surveyed, we saw no difference in gender, seniority, or current academic appointment. However, those who responded to the survey were more likely to have obtained NIH funding. Selection bias that's expected. When comparing awardees who received extramural funding after the award to those who did not, we saw that males were more likely to obtain extramural funding after their scholar grant, and those who had either already applied or intended to apply for a K08 were also more likely to obtain extramural funding following the grant. We then compared the mentors, whether the mentor was a surgeon scientist or not, maybe a PhD, and Blue Ridge ranking of the institution during the award, monetary institutional support, their research time, what was on the contract and versus their actual research time, and their research focus, whether it was basic translational research or clinical science. And we saw no significant difference in future extramural funding in all of these categories. Looking further at the research focus, we saw that 85% of the J. Grossfeld scholars studied basic and translational science during their award. However, 27% at the time of the survey had added a clinical focus, while 15% had actually converted their focus completely from basic translational science to clinical science. This isn't without limitations. There's selection bias and recall bias with it being a survey, low power due to the number of respondents we had. And we also have a lack of insight into the factors that led to unsuccessful procurement of extramural funding. And we also weren't able to account for other metrics of success, such as TV appearance, social media appearance, and book chapters that we're unaware of. So in conclusion, we learned that the intent to apply for a Mentored Career Development Award was associated with future extramural funding for the J. Grossfeld scholars. However, when we look at, institutional support monetarily, whether your mentor was a surgeon or not, or Blue Ridge ranking of the institution that you're at, those didn't stand out as significant determinants of success in this specific subset. Thank you for the opportunity to present, and I'll be happy to take any questions.
What do you think we should do with this data? Do you think there's any way to feed this into the selection of the candidates, or should it not? Like, what do you plan to do with this data?
I think that one, it goes to show that, what we are doing to support junior faculty at this time in their training or in their research experience is important, and it's yielding fruit. And so I think it serves as that purpose and maybe a motivator to continue to support those that are supporting these junior faculties. So the APSA Foundation, continued support and donation to the APSA Foundation to help further more surgeon scientists. So maybe this will help allow for more awards that can lead to more NIH funding and more research that'll be able to be done. And it could also be used to choose who is selected to receive these awards as well.
Why do you think there was a gender difference in those who received the funding?
It's hard to say. It may be that, when we looked at the data earlier on, there were more males that were receiving the awards. However, as the years went by, we saw it level out. And now it's more kind of 50-50 on male and female who obtained these awards. And so I think those earlier on who had obtained an edge, or those who had received the award earlier on, are more likely, due to lead time bias, to have obtained NIH funding at the time of the survey. And so I think that may be why we're seeing that.
Hi, Jamie Robinson at Vanderbilt. I had the benefit of reviewing the paper at large, which was great, so thank you. But just in doing that, one question that came to mind was whether or not we have the information and data to look at individuals who have applied for the award, such that you could have a controlled group to compare to. Thank you.
Great question. Unfortunately, we didn't have the information of those who, may have applied but weren't able to obtain. But I think that it'd be very interesting to look at that data and look at differences in the population and see where those who may have not obtained the award, where they are now and how successful they are.
Okay, thank you.
Thanks.
All right, Dr. Rebecca Morrissey will now present readiness of graduating general surgery residents to perform common pediatric surgery procedures.
Thank you for the opportunity to present our work. I am currently a surgical education research fellow at the University of Michigan, interested in combining my interests in pediatric surgery and education. And so this work is important in determining sort of how we evaluate general surgery residents who are not going into pediatric surgery. And I have no disclosures. So only 20 pediatric surgery cases are actually required for general surgery residents to graduate from residency. And this number has remained constant for over a decade. According to the ACGME, the most commonly logged pediatric surgery cases are umbilical and inguinal hernias. And while pediatric surgery is a very specialized field, and many general surgeons never encounter it in practice, we have previous work that has suggested that up to 40% of common pediatric surgery procedures are actually performed at an adult hospital, and this is potentially by a non-fellowship trained general surgeon. Around 15% of all graduating general surgery residents do not pursue any fellowship. Therefore, readiness to perform certain subspecialty procedures at the completion of residency might be necessary, especially for those who are practicing in communities that may not have access to a fellowship-trained pediatric surgeon. Unfortunately, we know pretty little about the preparation of general surgery residents to perform the most common pediatric surgery procedures at the completion of graduation. Using a phone-based application from Simple, we collected evaluations from US-based categorical general surgery residents between 2015 and 2023. These evaluations include information on the resident's performance, the resident's autonomy, and the case complexity. For this study, operative performance served as the main outcome variable for the model. To quantify the probability of residents meeting a practice-ready standard, we dichotomized the outcomes similar to prior literature, where you can see that a practice-ready standard is equal to a practice-ready or exceptional performance rating. We similarly have a second model looking at operative autonomy, and that quantified the probability of residents achieving a meaningfully autonomous standard. We performed a generalized mixed effects model using all simple procedures first. And we then performed a Bayesian generalized mixed effect model where we evaluated the association of prior performance to future performance. And this, again, was all using evaluations in the simple app. The model was set to predict the likelihood of a PGY5 resident achieving a practice-ready or meaningfully autonomous standard in their last month of residency for a procedure with an average case complexity. And we then generated model predictions for residents performing open umbilical hernia repairs in an adult and in pediatric patients grouped into either greater than 5 years old or less than 5 years old. We also evaluated residents performing open inguinal hernia repairs. Again, the groups are adult, pediatric patients greater than 5, grouped in the 6-month to 5-year range, and then less than 6 months old. We had a total of 113,621 evaluations from 94 general surgery programs. And of these, 40 programs included at least one evaluation for the pediatric surgery procedures of interest. The median number of pediatric umbilical and inguinal hernia repairs that were logged in Simple per resident was 1. And the most commonly performed umbilical and inguinal pediatric procedures were performed during PGY years 1 through 3. Graduating residents had an adjusted probability of being deemed competent to perform an open inguinal hernia repair of 94% for an adult. And you can see this is in comparison to 80% for a less than 6-month-old. For an open umbilical hernia, the adjusted probability of competence was 98% for an adult. And you can see that graduating residents were similarly competent for a pediatric umbilical hernia repair of both age groups. This is a similar slide, but for autonomy, and you can see the same trends here for operative autonomy as we did on the last slide for operative performance. And so in conclusion, this is the first study to analyze national resident competency data in pediatric surgery-specific procedures with the intent of providing recommendations for general surgery training and for the care of our pediatric surgery patients. Our study revealed that graduating general surgery residents are generally considered competent to perform pediatric umbilical hernia repairs, but are not necessarily universally competent to perform all pediatric inguinal hernia repairs. And specifically, they might not be universally ready to perform inguinal hernia repairs in patients less than 6 months old. And we believe these results are in line with prior studies, including the Right Surgeon, Right Child Initiative, as well as some of the recommendations from the Task Force in Oral Surgery. Thank you for your time, and I'll take any questions.
You know, you had kind of referenced that study that said 40% of procedures by children are, maybe done in an adult hospital, but you don't necessarily have any data to say that if it is or is not done by a pediatric surgeon. Is that right?
That's correct. The study I was referencing is not specific enough for us to know who's actually performing those procedures. And additionally, we also don't know the other resources that those hospitals have, including anesthesia and other hospital resources or where they're located.
And then my other question is that I know you guys picked umbilical and inguinal hernia because it was one of the most common procedures you had done. But realistically speaking, I wonder if like an appendectomy is a more common procedure that is done by adults or adult surgeons as opposed to pediatric surgeons, just because that's not elective and so it's more likely to be done. Was there any consideration about applying something like this toward an appendectomy in children?
Yeah, thank you for the question. We had been interested in including appendectomy in our study. However, unfortunately, Simple doesn't differentiate between a pediatric and adult appendectomy. And so we just didn't have that data available. In the future, we're hoping to work with them to create more specific title names. So when residents or fellows are logging cases, we would have that availability.
And then, do you think that, I know Simple is what the tool that you've used, but if you look at our general surgery EPAs that have rolled out this past year, there's no EPA for pediatrics at all, like nothing is like age specific. Do you think that, that's something that should be investigated or, should be considered?
Yeah, absolutely. That's a great question. I think, one of the main things we think about in education is, especially as the EPAs are coming out, is measurement burden. And so there's always going to be one side of the coin to include more procedures and more assessments of different things. Obviously, as I stand here, I would be happy to advocate for pediatric surgery procedures and a pediatric surgery EPA, but with the understanding that that may not be applicable for everyone. So I think really figuring out what our goals are, again, in line with the Rural Surgery Task Force and in our groups, to sort of identify what do we want to focus on, what do we want our graduating residents to be comfortable with, what might offload from us and be a useful collaboration. Once we figure that out, I think we might be able to make a decision about the EPAs and other training recommendations.
I'm going to ask my question afterwards because we are running out of time.
Yeah, thanks.
Thank you.
Okay, so we're going to go on to the next one. It's going to be by a medical student, Owen Cordaro, that talks about the influence of pediatric surgery resident orientation program on documentation of appropriate specific acute appendicitis billing codes and hospital reimbursement from the Jacobs School of Medicine and Biomedical Science in Buffalo.
Good afternoon, everybody. My name's Owen Cordero, and I am a medical student at the University of Buffalo. This presentation is on enhancing hospital reimbursement through a pediatric surgery resident orientation program. We have nothing to disclose. Medical coding is an important tool for any practicing physician. However, there may be many residents who don't have a formal training within medical coding. For this study, we used the unspecified acute appendicitis code, K35.80, and compared it to the specified acute appendicitis code, K35.30. Usage of that unspecified code may lead to decreased hospital reimbursement and therefore less resources for supporting surgical patients and surgeons. We hypothesized that usage of a formal resident orientation would improve documentation of appropriate billing codes, leading to increased hospital reimbursement in pediatric acute appendicitis. This was a retrospective study. Our pre-orientation group consisted of residents who did not undergo a resident orientation program, and our post-orientation group were residents who had undergone the orientation. Our inclusion criteria include patients with a diagnosis of acute appendicitis with either the K35.80 or the K35.30 ICD-10 codes. For the resident orientation, the residents underwent training on ICD-10 diagnosis codes specifically for acute appendicitis. Within the program, the residents watched an instructional video. They had an in-person discussion with a faculty member on coding specificity, and they also had to answer some questions on a service orientation assessment at the end. For our results, the more specific diagnosis code, K35.30, went from 3.6% usage in the pre-orientation group to 87.5% usage in the post-orientation group. We also did an analysis for billing differences and adjusted for inflation. The average reimbursement per case increased from the pre-orientation group to the post-orientation group by an average of $661.07. Overall, the total adjusted hospital revenue increased by $84,616 over the same time frame. This was all due to one change in ICD-10 coding for a more specific acute appendicitis code. In conclusion, a resident orientation program might improve proper adherence to billing specificity after pediatric laparoscopic appendectomy, leading to increased hospital reimbursement. We recommend that teaching hospitals where patients undergo pediatric appendectomies should consider implementing a resident orientation program that covers medical coding and billing. I want to thank you for your time, and this is a list of all the different acute appendicitis codes. Highlighted in red are the 2 we used for the study, but you can see all of the other ones that may be used if needed.
Seattle Children's, great talk and great presentation. Fascinated by your results. Quick question is, at your institutions, your residents are doing the coding and billing, or do you have faculty and billers and coders who actually do that?
So at our institution, the residents they are putting in the orders for the coding, for the specific coding, but faculty also does that as well.
Great, thank you.
Alfred Shaheen, Atlanta. Thank you for the presentation. I just want to elaborate on Dr. Lee's question. So the residents enter the code as an order when they admit the patient for the operation and the ICD-10 code?
After the operation, the resident will submit the ICD-10 code, and that will be what is put in for billing. And we have one of our attendings.
Okay, I have another question regarding to attendings. And during that same period with the orientation, were there any other differences? Were the attendings more aware of that? Were they correcting things? Was it? Are we just looking at a resident effect here, or a Hawthorne effect from everybody else as well?
That wasn't something we looked at specifically. In the term of what attendings are going to put in orders, we only looked at resident orders after the orientation program.
So often the residents will put in diagnosis codes into the EMR, which then get incorporated into the note, and those can be changed by the attendings. This was a focus on attending coding as well as resident coding, and so there may be some effect of both there. But many of the codes were initially put in by the residents in the second half, and so our coders and billers weren't as cognizant as far as the difference in hospital payments for the 2 different codes until we started having more discussions about it, and then they started paying more attention to it too. So it's probably multifactorial, and not just the resident orientation program, but the emphasis on getting the right code still has a significant impact on the hospital reimbursement.
Great. Thank you very much.
All right, Dr. Nicole Chacon will present Gather, Generate, and Teach Health Equity Routinely, Changing Surgeon DEI Behaviors Through a Novel QI Framework.
Hello, everyone. My name is Nicole Chacon. I'm a pediatric research fellow based out of Seattle Children's Hospital, and today it's my privilege to present our work on Gather, or Generate and Teach Health Equity Routinely, a novel DEI program that was developed by Dr. Shaquita Bell and my co-authors listed below, and the impact this program had on the surgical providers at our institution. My co-authors and I have nothing to disclose. So to begin, why do this work in the first place? Well, bias, racism, and discrimination are widespread within our healthcare system, and they have lasting impacts on not only our patients, but also the clinicians and trainees who care for them. It's imperative, at least we feel so, that as clinicians, we create environments that confront inequities and center on DEI in order to help change this. However, minimal published data about the effectiveness of certain educational interventions to improve clinician DEI behaviors exist, specifically any peer-driven interventions and assessment of long-term improvements. Therefore, we created and studied a 3-session peer-driven QI project known as Gather, and studied the impact it had on the surgical providers at our institution. We hypothesized that there would be improvements in these equity-focused behaviors as compared to a participant's baseline in the program. So just a little bit more background on Gather. Gather was developed as part of our institution's commitment to equity and anti-racism. It's a 3-session program given over a 3-month time period. There are 3 frameworks that inform Gather. Critical theory, which uses individual reflection as a link to better understand and assess larger systems and their impact on health equity and the learning environment. Critical race theory, which uses a multidisciplinary approach to understand race, racism, power, and the structural inequities in everyday life. And then QI, which really emphasizes action-oriented learning and targeting areas of improvement through data collection and trends over time. The premise for Gather was for it to be peer-based discussion and to also utilize some self-reflection. Participants in Gather were asked to report the frequency of their 7 DEI behaviors using a 7-question survey that was given before, during, and after the intervention. And while there isn't enough time for me to delve into the specifics of the survey questions, they do cover topics of barriers, privilege and oppression, DEI training, assumptions, burdens of care, and conversation initiation about DVI, as well as assumptions of care. We utilized a prospective cohort design over a 23-month time period. Participants who enrolled in Gather and completed at least 1 self-assessment survey were included in the analysis. For the analysis, participants reported the frequency of the 7 DEI behaviors using a Likert scale at the time intervals that you can see on the side of the screen. So monthly for the first 3 months pre-intervention, weekly for the 3 months of the intervention, and then at 1, 2, 3, and 6 months post-intervention to see if there were any long-term improvements. Upon completion of the study, we then used mixed effects logistic regression modeling to model the probability of often or always engaging in these DEI behaviors. So I know it's a little busy, focus on the bolded values. Compared to baseline, there were increases in engaging in DEI behaviors after participation in each session. And these were significant for the first 6 behaviors after just 1 session of Gather, and then for the 7th behavior after the 2nd session of Gather. And what's really interesting to note is after even 6 months down the road after completion of Gather, that these changes were still significant. This is a visual representation of the same data. And as you can see, there are improvements in all 7 of those equity-focused behaviors over time. So what does this all mean? Our study demonstrated that through our DEI program, Gather, surgical clinicians demonstrated significant and sustained improvements in all of the equity-focused behaviors that we assessed. These improvements, again, were across all behaviors studied and encompass various aspects of patient care, interactions with trainees, and even administrative work. We feel creation of spaces for clinician development is vital, and that self-assessing equity-focused behaviors is one arm of a larger intervention that can be implemented by an institution as we continue to foster and normalize our commitment to DEI. Now, there are some important limitations to note, primarily that these are self-reported outcomes, so they may reflect a participant's beliefs, but not their actual behaviors. And additionally, there may be some self-selection bias in our participants. In the future, we hope to continue to expand out our program nationally, to continue to do deeper dives to better understand the influence this program had on our participants and our patients, and then to utilize objective data from 360 evaluations to better support our findings. Happy to take any questions, and my contact information is listed below.
How hard do you think it'll be to get peer observations or peer ratings or like 360 assessments?
So we're actually already doing that. Okay. So the way we've gone about it is basically when a participant is enrolling in Gather, they then basically give 3 individuals, one who's kind of higher above them, one who's at a peer level, and one's below them to kind of observe them both pre and post with surveys.
All right.
Any other questions?
Okay, thank you.
Cool, thanks.
Okay, so the last talk of the session is by Dr. Parker Evans from surgery resident Vanderbilt. It's going to be about the impact of a pediatric ambulatory surgical center on surgery resident education. Thanks.
All right, good afternoon. My name is Parker Evans. I'm a general surgery resident at Vanderbilt and a biomedical informatics research fellow. I'll be talking about the impact of a pediatric ambulatory surgery center on surgery resident education. I have no disclosures. In May of 2020, our pediatric surgery group started performing select cases at an ambulatory surgery center about 30 minutes outside of town. And we did this research because we were concerned that shifting cases to the ambulatory center, despite the advantages to the health system and to patients, may have had a negative impact on the operative experience opportunities for our surgery residents and pediatric surgery fellows. So as we'll see, the reason this data is important is because the ambulatory center ended up representing a missed educational opportunity for our trainees. For our methods, we did a retrospective review of 2 different data sources, the EPIC electronic health record operative log data as well as ACGME case log data. We compared resident operative numbers from before and after that May 2020 time point, which is when cases started at the ambulatory center. We looked at total case numbers as well as overlapping cases, which were the case types defined by CPT codes that were performed at both the main children's hospital at Vanderbilt as well as the ambulatory center. I'm a data nerd, so just a quick background on our data sources here. So the EPIC Clarity database, anytime a case is performed at an EPIC center, it generates a data structure that looks like this, which ultimately can be utilized. And at our center in particular, the circulator nurses log resident and fellow participation in these cases, which is how we were able to track this. And then I'm sure most people in the audience are way too familiar with this particular screen, but this is the data submission form for the ACGME case log website. These are the overlapping case types for the subgroup that we analyzed. As you can see, the most common case types that were done at the ambulatory center were hernia cases and some soft tissue lesion excisions. And here's a look at the overall case volume at the centers. So on the left is the case volume before the ambulatory center started doing cases, and on the right is the volume afterwards. And as you can see, the average monthly volume really didn't change at our main hospital. Neither did trainee participation in cases at the main hospital. But the really notable finding here is that of the 600 or so cases that have been done at our ambulatory center in the last 4 years, only 9 of them have been participated in by trainees of any type. Here's a graphical representation of some of the same data. You can see that over time, especially in the last few periods, a greater proportion of cases have been done at the ambulatory center as compared to the main hospital. This is the electronic health record data that we looked at. So we looked at residents in PGY years 1 and 3, which are the 2 years that our residents rotate on the pediatric surgery rotation. And we looked at first and second year fellows. So on the left, you see the total case numbers, and on the right are the overlapping case subset numbers that we talked about. And really the take home point here is that there were no meaningful decreases in case volume based on the electronic health record data set, really at any level that we examined. The one statistically significant decrease that you can see there is a slight decrease in second year fellow numbers for the overlapping subset cases. This is the ACGME data, which we have structured here the same way, looking at first and third year residents. And again, the story here is consistent that there were no real meaningful decreases in case volume based on the ACGME case logs either. So contrary to our hypothesis, we found no evidence of deleterious impact on operative case volume for pediatric surgery cases for either our general surgery residents or our pediatric surgery fellows. And then as a side note related to ACGME requirements, the 20 case minimum was met by all of the residents graduating from our program during this time period. So really our main learning point here was that this ambulatory center really represents a missed educational opportunity for our trainees. We're not really getting any of our residents out there, and they're doing a lot of great cases like inguinal hernias, umbilical hernias that would be excellent learning cases for residents and pediatric surgery fellows both. So we actually interviewed a lot of the residents, or some of the residents who did try to go out there, and something we learned was that a couple of residents went out there to do cases that day and were actually turned away at the door by the staff saying that they weren't allowed to take part in cases. So there are definitely some multifactorial barriers in place, and this is something that we're interested in working on and getting our trainees out there. There are some limitations to both data sets in terms of their sensitivity, and I'm happy to talk about that if there's a question. Thanks for your time.
Hey, I'm Mark Ryan from Dallas. Now this is interesting. This is a great presentation. Thank you. The the question I have is, so the case number didn't change, and you diverted, so the thing with the tiny cases in the big hospital is it's sort of like using the cruise ship as the Staten Island ferry, because like it's just harder to turn around the boat fast enough to get these guys out. And so the question I have is sort of so the numbers stayed the same, but can you comment at all on the case mix? And so is that they're not getting to do the hernias and some of the lumps, but are they sticking around and maybe getting to participate in G2s or major cases? Or so is it more like now they get more quality over quantity now that you're diverting a big handful of the smaller things to the ASC?
Just to make sure I understand your question, so you're asking about the specific types of cases that shifted from the main hospital to the ambulatory center, and did that have an effect on kind of trainee case mix volume?
So what I'm interested in is the sort of the case mix for a resident that goes through your program, sort of now that you've sort of diverted a segment of sort of shorter procedures. So now does their sort of resume now include a lot more sort of major cases, complex cases, like or just different cases? I'd be curious to see what their case mix looks like now.
Understood. Thanks for your question. We did look at that, and that was part of the reason we specifically selected for that overlapping subset, so that we could look at case types that were being shifted over to the ambulatory center. And those numbers really showed that there may have been a slight decrease at some training levels for some of those, but they were still catching a lot of those cases. But really our case mix is kind of most differentiated by experience level at our institution, so that interns are doing different cases than the PGY3s, who are doing different cases than the fellows at some level. So I think that really has a bigger impact than the fact that they shifted some of those cases to the ambulatory center. I don't know if I totally answered your question.
Great presentation. I'm curious as to who turned away the trainees. Was it the faculty or was it the operative staff?
It wasn't the faculty. They were actually the ones who told the residents, hey, meet me out at Murfreesboro so we can do some cases at this ambulatory site. It was the staff. So sometimes it was the circulator or the nurse manager for the day. So miscommunication there.
And I think as surgeons here, and really appreciative that we enjoy having our trainees with us at outpatient centers, we have to be the ones to lead that say, hey, no, we need our trainees with us in these settings. They need to learn this. They're not going to slow us down so that you can go home earlier. We've shown that. We've had a faculty member say, I'll purposely go slower if everyone brings that up, to make the point that we want our trainees out at our ambulatory surgery training centers. So thank you.
Thanks.
Thank you.